I'm live? Oh my gosh. Wow. Finally live. Welcome. This is Advanced General Dentistry. Our office is named Renew, and I'm Dr. Todd Wedeking. We are attempting to do a live stream on Facebook and YouTube. So our primary live stream and our recorded videos that have been edited for brevity but also for educational purposes are on our website, but those videos are on our YouTube channel, so you can take a look there if you're on Facebook. We will be on Twitch and Mixer and possibly Instagram too down the road, but we'll figure out those technical difficulties. And the purpose of the live streams with Advanced General Dentistry is for pretty much everybody. And what I mean by that is most of the clientele that I see have a lot of various dentistry, whether it is a mixed dentition like this where you have implants, crowns, bridges, fillings, veneers. It could be anything that people face typically in their later years, but I do see younger people that have very difficult problems due to bone anatomy and bone density. So the types of topics I talk about aren't just about drilling and filling, and you can learn a lot not only as a patient, which I want to elevate the dental IQ of everybody, but as a patient when dentistry is getting more and more expensive and it's more and more out of pocket. Becomes less affordable. So when you get to bigger cases where there's multiple implants or large bridge pieces here, these cases are a little more difficult to discuss with the patient because they involve multiple teeth. If you think about dentistry, if you're the public, you think of it as like you go in, you get something fixed and you leave. And it doesn't really dawn on you that there's a big biological factor going on, meaning you have to have some sort of healing, or you have a habit or something that might be contributing to your teeth. Now, everybody has a different story, whether it's diabetes, whether it's smoking, whether it's they have a habit of chewing on bones or hard things, they like chewing on ice. Those are biomechanical events, and they're biological events. There's pharmaceutical events, which are biological events that could affect your dry mouth and cause decay. You can be electing to celebrate every holiday, everything you do with candy and sweets, or you don't have a good habit of brushing. So we're going to talk about a lot of this stuff, and we're going to be talking about it periodically through patients that I see on a regular basis. So this case here is a case that's been, I think I saw him maybe 5+ years ago. It's been a while. We see him periodically. He lives about 25 miles away, so he doesn't come to me always, or our office. We don't always have general dentists to do a lot of the general dentistry. Sometimes they move on, they move out of the office, they buy somewhere, they move out of the area. But anyway, so this fellow has been in and out of dentistry for a while in our office. I haven't seen him in about 2.5 years. He had a lot of dentistry done actually in Brazil. I think what we did in our office was this 4-unit bridge because he didn't have the bone quality and the bone size available. The geometry of the bone wasn't available to do implants. But clearly he has implants on the upper as he was losing those teeth. So our purpose here is to elevate the dental IQ. And if you are a dental student, we do training in our offices with pre-dental students. We give them an opportunity to shadow or work as a dental assistant. They learn a lot just from a practical experience in a little bit of a different environment than a traditional office that has hygiene and a lot of movement in general offices. we tackle bigger cases, so our appointments are more, an hour to even 3 hours long. So we might see only 5 to 6 patients a day, whereas a general practice could see upwards of 20 people a day coming through for one doctor. And that starts to be a high volume type of practice. So if you are a dental professional, please look at our edited versions of our case studies. We will be offering subscriptions to a database so you can understand how to treatment plan better before you have problems with your cases, as well as I teach different classes. There's a dental implant 101 class. I teach a sinus grafting course. I teach socket grafting courses. I teach dental marketing, dental office management class. So I've been doing this for years, and we will be tackling those as a subscription form for dental professionals. But if you want to see some of the case studies, they run about maybe 10 to 20 minutes long at most, I hope. I try not to talk that much there, but they are edited a little bit, so you get right to the heart of what the purpose of that case study is about. And I will talk about small cases where it's just a single tooth replacement, or I will talk about things that would be for a full arch and how you make those decisions. It's very, very difficult for people to understand how decisions should be made. I get this all the time when I do exams with patients. They're always very grateful that I've actually sat down and actually talked to the patient and thoroughly explained the various choices. There are always choices. It's very seldom that I run into cases that they don't have a choice. And they should know. Patients should really have the education, and I personally really like patients that are educated, that they are able to make the proper decision. That is their life, and I feel like they have to have control and a complete understanding of what they're choosing and elect to do with their mouth and with their dentition, and what are the actual pros and cons, the costs, the benefits, etc., towards it all. So let's talk about this case. Like I said, this is a gentleman been living in Brazil for a long time. For those Brazilian doctors out there, I give a big shout out to you guys. You guys do a great job. There's so much dental research going on in Brazil. I wish I spoke Portuguese. I do not, because there's so many research articles I want to read that are in Portuguese, and so I got to get the translated version somewhere. But also, your beaches are great, and I think it's fantastic. They have the best setups that they have at the talks and discussions and tabletops. The Brazilians have got it. They got a lot of dentistry going on, a lot of research going on. It's really awesome. They really move the field along. And so this gentleman had been living down there for 10, 15 years, I believe, before I saw him when he moved back. Teaching, he loved it. He has nothing but good things to say about being down there. But let's get forward. And my next shout out, by the way, is for Camp Kesem. For those of you students out there, join a camp. Unfortunately, we have the COVID stuff going on, so Camp Kesem got canceled. But if you are on any of the campuses, I think there's about 115 or 120 campuses for university students. If you're a pre-dental or even medical student, look into Camp Kesem as a volunteer activity. It's a great nonprofit for kids that have parents with cancer, and it's a great opportunity to kind of learn a little bit more about that field, which I'm very excited about to help out with as well. So here we go. So why does somebody come in 2.5 years later? It's always a concern when I see somebody that I haven't seen for years, and typically it's only to solve a problem that they have. They don't come in just to say hello and want to shake my hand and then they leave. Very few do, but I don't really have a lot of time to be cordial. But the point is that he made an appointment, and I know this gentleman has a big bridge on the lower right side. He's got a very strong bite. He's like, and then he's got implants too. So you're always wondering, like, oh my gosh, should he pound his implants out of his head? Does he have an infection? Does he need a new bridge and I can't solve this grafting problem? Who knows what it is? He also has root canal treated teeth right here. So you're kind of like, oh no, what's going to happen with that? So actually what he came in for is this premolar right here. So that premolar here is where he was going, well, it's starting to be sensitive and he has a difficult time biting on that area. And what's kind of strange here, the people that have these really, really hard bites, this is one of them, they can't tell how hard they're biting, and they can't tell that they have like a big infection going on where it's like massive swelling. They've got, you know, pus or something. They just go, something's kind of wrong. Whereas other people, like, they'll have a little crack and a little bit of movement or whatever, and then they go, oh my God, they're in massive pain and the PDL is swollen and all these other things. You know, everybody's different, like I said, but the ones that just have this real strong bite have the least sensitivity to everything orally. They just don't have that sensory feedback that really helps them out. And I don't know if that's just they're born that way or is it conditioned that way over the years where they just keep grinding and grinding and grinding and kind of that's the level of sensory that they have. It kind of like diminishes. I'm not really sure. So let's take a look here. I'm going to bring our scan view here. I'm going to bring it, let's say, over to this tooth so we can look at that tooth. It's a little bit on the grainy side. Here, that's the canine. And now as I come along, the problem right off the bat when we look at a CT is how to look around the artifacts. X-rays are X-rays. They cannot see through metal, they cannot see through zirconia crowns, and it's difficult for it to see through anything dense. And what happens between like implants and anything close to an implant or a metal crown is you get the starbursty pattern crossing over, and in between when those waves hit they can create a blackout. So the black areas here are the ones that are blackened out due to artifacts from the metal rebounding off the CT going around the head. So you see that here in this view. You'll see this kind of scatter going across, and as I go, let's say, down closer to where the actual metal is here towards the teeth, you can just see how much starburst patterns there are, and you lose a lot of the definition. So you know, that's the real raw data, and you want to see what the raw data is showing, because software designers can kind of clean this stuff up and give you a best guesstimate and give you a pretty picture, but I don't like things that are altered. So if it has a lot of distortion, then cleaning it up is fake too. So I like the idea that I do see some distortion, so I really see what the real data is that is actually being viewed. I would love to see some other imaging products that might complement this to clear this up somehow, you know, or sensors being much better to dealing with it at the source. So, but anyway, that's where we're at. And as we go down, here's the tooth that we're looking at. And right here, something doesn't look right. We're looking at it right through here. There's this kind of ghosty image across, but there's definitely something not quite right down into the root, because we have bone loss too. This is a tough thing to actually see, but let's go back to this site here. When we do the slice view, you can see the fracture now coming through right here. And that's a pretty clear image of a fracture. My suspicion is that this patient had lost the nerve a long time ago, but what happened is that the body has not identified. Here's the fracture. You can see it following all the way through. As I scroll through and I see that continuous fracture all the way through the root. It goes right here and goes right here. There it goes. And that's it. And it's fractured down. So what's happened with him is that the nerve had died, and whenever a tooth becomes devitalized, like when you have a root canal, it becomes very brittle. I try to describe this um, as a brick building versus a steel building, and everything is earthquakes. Earthquakes all the time in the mouth, right? You're biting, chewing, you're grinding, you're clenching, you're gritting your teeth, whatever you're doing. Earthquakes. So here we go. Now, once a tooth is brittle, you know, this is in a primary chewing area. This is the premolar area on the upper, and so he's got a lot of force. He can't always tell how his load is, and he's probably smashed away the PDL. PDL, for those that don't understand what the PDL is, the periodontal ligament, which holds the tooth to the bone. So you have the tooth, the root structure is attached to the bone socket, which is attached by a ligament, and that's called the PDL, or the periodontal ligament. That ligament can be calcified as well. It could also be just so crushed, you know, all the time, and it doesn't have a chance. And the patient could have been doing that. Doesn't matter. There's still always a PDL somewhere, whether it's calcified or not. It just becomes more ankylosed or what. Doesn't matter. It's a devitalized nerve, just like a root canal treated tooth, and becomes brittle. So that's the brick building in a earthquake situation, and it just needs a small propagation of a crack before the brick building starts to fall down and kind of crack and break. And this could have been done 20 years ago, 30 years ago, and it's finally now, what is he? He's in his 70s. You know, it's finally now taken it, and his jaw muscles are still like through the roof strong. So with him, he's probably grinding side to side. He doesn't really know. He's really clenching hard, and finally cracked this out. So the only way to really evaluate this is we take the crown off, and I'm looking at the underlying movement of that tooth. And it was mobile, and it didn't take much to numb that up around the gum tissue, and then I just kind of pulled it right out. It was very simple and straightforward, except the root tips. Now I'm really stuck with these really tiny root tips that were stuck in there, that made it a little bit more challenging, because he doesn't have a great, let's see if we can find a good picture of that. He doesn't have a lot of ligament space here, and those root tips are really small and very fine. So that took a little bit more time to kind of whittle those out, but that's possible. So once that's done, and now we look at this case and we say, okay, well, what can we do with him? Let's bring it back to, let's see, we moved everything away. Let's bring that back. Blah, blah, blah. All right, almost there. And then let's make it bigger. Let's go to 15. Uh-oh. Must be way ahead. There we go. All right. So this is the tooth we're looking at. Now, here's the problem. What do we do here? Do we do another implant? Yes, he's got bone. We know, well, first off, we know we're extracting it, which we extracted it. But restoratively, we can do a few things. We're not going to jump on cutting these crowns out. You can cut these crowns off of here, cut that, take this out, and now you do what we call a cantilever bridge. You could do that. I wouldn't recommend it in this patient's case, because the etiology here is that he's got a very strong bite, and that really strong bite is the problem, and you don't want to create a cantilever or a stress on this implant that's been in there for a while, and we not really a high recommend to do a cantilever here, even though you can. That's the point. You could do a single implant here, which is what we elected to do, of course, And here's one that's taboo to do, is a 3-unit bridge between a natural tooth and an implant tooth. So you could do a crown here and take that crown off and do a 3-unit bridge. Now, it's taboo because they talk about the natural tooth having a ligament space, and the ligament space has a little bit of give to the tooth, and it kind of like is the shocks on the car, where when you go over bumps, it kind of keeps the car steady. And in a natural tooth, that's the way we think about it. Versus an implant tooth, or implant rooted, or a crown supported by an implant, is fused to the bone. There's no ligament, there's no shocks on that car. So the concept is, when you bite on one that's moving, let's see, one's moving, one is fixed. That means if they're connected, that as one moves, or let's say this one moves, you're going to have stress on the bridge, which is going to stress right here on the neck of the one that's fixed. And so the idea is that movement can cause the biomechanics around the neck of the implant to cause bone loss and things like that. I'm not a believer of this. So if you're a doctor out there, anybody's professional watching this, yeah, you're probably going to disagree. But here's the logic, and this is what I see, because about 5 to 8 cases a year, because I see a lot of cases that I need some sort of solution. Sometimes I can only do some sort of fixed bridge in that case, where I have to go implant to natural tooth unless I want to take the natural tooth out. Most patients don't want to do that. So what I recommend is, on one of the crowns, usually the implant one, I will put a temporary cement on it, get a little bigger cement gap around that bridge, so that if anything becomes non-supportive in the biomechanics of movement, let's say this natural tooth is moving up and down and this one's fixed, if I have cement here, that's the give. So now this crown moves, but the implant doesn't get stressed. I also feel like in this case, I think there's an argument for this guy's a heavy biter, but doesn't have a big ligament space on his other teeth. There is no little movement. So the older you are, the more that ligament space becomes fused or compressed, or basically petrified, and the tooth becomes ankylosed to the bone. If the tooth is ankylosed to the bone, you basically got an implant, right? It's ankylosed to the bone. So why not connect a natural tooth to an implant? You got the same situation. So I look at it case by case, and I agree. Yeah, there's logic to the idea of not doing the taboo between an implant and a natural tooth, but I think I've never seen a problem, and I will knock on wood too, just in case, but I gotta say, I've never seen a problem with any of the cases that I've done in the past where I've done a natural tooth to an implant case. The only problems I can see is that when that patient goes to other offices and then they badmouth me for doing something like that, when they don't even understand the situation at all. And that's my biggest problem, is that the lack of dental education amongst professionals seems to be very, very low when it comes to thinking out problems like this. So please, if you're a dental professional out there and you disagree or whatever, or you agree, please write a comment, do something. Let's have a discussion, because I have not seen that problem, and I understand what Carl Misch has said. I've read all these things. I don't see the evidence. It's just, there's no evidence for it. I don't see that there's enough evidence for the claims that have been made. So I think it's a little taboo. I think it's case by case, and I think you got to kind of be aware of what you're actually doing, obviously. So the simple fix is to deal with it that way, with a single implant case. Patient, we did an immediate placement. All looks great, and we will see him in the 3.5-4 months that we usually wait for integration. So that's the end of today's case. Everything else looks great. We're not going to talk about all the other stuff with this guy's case, but we will be hopefully streaming on Saturdays And we will try to find another time or two during the week to do more streams, live streams on Facebook, YouTube, Twitch, Mixer, and we'll try to get to Instagram sometime too. So thank you very much. We will see you another day. We hope that's all good. Cheers.